The following program is underwritten by the Nevada Irrigation District. Since 1921, providing clean and healthy drinking and irrigation water to more than 24,000 homes, farms, schools, and businesses in Nevada and Placer counties.
Hi, I'm Lew Sitzer, the host of NCTV Interviews. This is the second in a series of shows on the healthcare issues in Nevada County. And with us today we have Dr. John Jackson, Dr. Gail Fredericks, physical therapist Walt Abbey, and Dr. Dan Biebelheimer, who is a retired doctor who serves as medical director of Sierra Nevada Medical Associates. This is a group of doctors who are organized under the title of IPA, which is Independent Physicians Association. And they have formed a group to better serve the community of Nevada County. And the group operates under an HMO. And we're here to explore what that means, what the various titles and descriptions, because health issues are a concern, particularly in our community, as it is an aging community with many questions about Medicare, Medi-Cal, HMOs, PPOs. There's a whole vocabulary that goes along with the issues of healthcare. So we're going to be asking questions of the doctors and physical therapists, and we'll be further exploring the topic of how to get appropriate health care in Nevada County. So first I'd like to talk with John Jackson, who is a doctor, long-term, 18 years in the community, as are many of the doctors that will be talking today, well versed in community issues. And so we're going to be talking about what a provider is and how that term also used as a gatekeeper, kind of a negative connotation, but the idea of how health plans better serve you and your medical issues. Primary care provider, what does that actually mean? John?
Well, a primary care provider is typically pediatricians, family practitioners, general internal medicine. That's your access point to your health care.
So intro, and these are the people that you would encounter first off.
Right.
And I would assume, from what I've understood, that one of the benefits of health coverage is that you get to see a doctor in their office and you're not dealing with emergency care. I mean, you're not going to the hospital and racking up bills. I mean, I guess we'll get into that at some other point. But the idea that this is a service that is provided for initial contacts.
Well, and you develop a relationship with this individual and hopefully develop some trust. And so the patients feel like they have a place to go or a place to start, and they're not just kind of encountering this monolith of a healthcare system.
Great, great. And I know that within the system of HMOs, there is this term gatekeeper, and I wondered, Gail, if you might respond to that.
I despise the word gatekeeper. It implies that the primary care doctor is trying to prevent patients from receiving the care that they need. And that is absolutely not the case with the primary care doctors in our IPA. First of all of the members, all of the people who are insured through our IPA are guaranteed a primary care doctor. As Dr. Jackson was saying, as John was saying, that creates a relationship between the doctor and the patient that extends over years of time, and in many cases over generations in a single family. So the term gatekeeper I very much dislike. We, as primary care doctors, see our responsibility as trying to assess what problem the patient has, what can be done about it, and if the patient needs to see another doctor, a specialist, to provide that referral, set up that relationship then between the patient and the specialist.
Right. So I know that HMOs and gatekeepers have been charged with, trying to make a profit above, at the cost of a patient's health. They'll sometimes be denied access to a specialist or to an operation because of the profit line. And what I hear you saying is that in this community, that is not the case.
I agree with that.
Well, and I think part of the advantage in our community is that it's this community of doctors that owns the IPA, and it's not a select few shareholders at some distant location that have a certain quarterly return that needs to be demanded. I mean, this is, like Gail has said, it's hard to deny people care when you run into them at church or at Little League practice or at school. These are fellow members of the community, and so you're going to take care of them.
So what happens, though, if you run into, as you mentioned, a Blue Cross or a Blue Shield that you administer locally, and I would assume they have their own, quote, gatekeepers. How does that interaction work?
Well, as the medical director, my job is to review referrals and make decisions about whether the request for a certain kind of care is appropriate. At the national meetings, it's been pretty clear that HMOs have, the healthcare system has squeezed out all the waste. And it is clear that denying care is not going to benefit the system. What you need to do is provide quality, do it right the first time. So for the most part, our job is not denying care, it's more how about guiding it.
But those aren't maybe what we're hearing in the news is the exceptions to the rule where someone feels that they have been short-shrifted.
Yeah, and the health plans are very good about doing a great deal of research, looking at is a particular new modality, new procedure, new drug appropriate? Has it been researched carefully? Is it evidence-based? Is it something that should be covered? And some of the controversies have been on these fringe things that were not yet clearly beneficial, which years later now we realize some of them in fact weren't. And the restrictions and cautions about those were justified. So the plans are very good about providing us with guidelines about what is reasonable, what is appropriate, and I've been pleased to find out that so many of the newer procedures and things are in fact benefits.
Well, and I think kind of tooting our own horn being primary care doctors is that we do act as the advocates. I mean, we're not an insurance company, we don't sell, basically we provide service. And so we don't sell, procedures or medications. Our profession is the service. And so we sort of sit at this crossroads between a culture that really hustles things and stuff and medicines. I mean, just the number of times you're supposed to ask your doctor about, on the commercials that we see on television. So we can really sit in and have the perspective of being trying to judge for that individual patient whether this exotic thing may be appropriate or whether it's just hustle. And I think that is something that we have special here.
And I have the ability to pick up the phone and dial Dan's number and talk with him personally and try to explain why I feel a particular patient needs a particular procedure or referral.
What about the people in our community who think, well, I've got a serious illness, I'm going to go to San Francisco, Stanford, Davis, because facilities and care here is just not up to snuff. How do you respond to something like that?
Honestly, what I share with my patients is at the medical school where I went to school, we had this famous thoracic surgeon, and we asked him where he'd go for his heart surgery and stuff. And he said, Birmingham, Alabama. And we asked him, well, why go to Birmingham? You could go to the Mass General or the Cleveland Clinic or Texas Heart Institute. He said, there was Dr. Yarborough's there. I know Bill Yarborough. He takes good care of his patients. And so that's what I share with them, that it's your individual doctor. It's not the stuff. It's not the technology, with few exceptions, that really is the good care.
And I think that a real credit to our medical community is that, for the most part, our doctors choose to stay in the community to receive care themselves and for their families.
Mm-hmm. Clearly there are some services we don't have locally, and we have access to physicians in Sacramento for specialty services, and we also have connections with UC Davis, Stanford, and University of San Francisco.
So and that's where I was going with it, that if for some reason we didn't have the expertise, that the network could in fact recommend and direct people and still be covered within the network.
Right. We have access through the plan.
And it's not an extra charge to the patient. It's part of the coverage under the HMO plan.
How do fees differ from a doctor's perspective or from a therapist's perspective? Is there any difference in HMOs versus PPOs?
Well, in HMO, we're paid we're sort of paid by what's called capitation, which we were sort of, patients or for every patient, we are paid a monthly fee. And it depends on how old you are, what sex you are. And so we're paid in that way, so it's not sort of generated by demands for visits. It so basically gives you, here's your responsibility for this patient.
My reimbursements are very reasonable. They allow me to create a quality environment for the patients through my contract with the group. It's on the Medicare fee schedule, basically, which is acceptable, reasonable, and allows me to maintain a good staff and provide continuing education for my staff and good equipment and a nice space for the patients. So it works out very well for everybody.
And you're bringing up Medicare. I was just curious because it's another fee schedule, and I was wondering, with an aging community, there are more and more people on Medicare. How does that affect what you're doing within the HMO and what you're doing with patients who are under Medicare?
Well, some patients that are just straight Medicare, or they may have their secondary plan, may not be part of our plan. There is an HMO, there's a Medicare HMO plan available in our community, AARP Medicare Complete by Secure Horizons. And that is available for Medicare patients and is administered through our plan. And it actually pays our physicians a bit better than Medicare, which is, and also because if they have that plan and they have Medicare, some patients with Medicare have had difficulty getting access to physicians. And with their Secure Horizons through our plan, we can provide access.
Great.
any of our HMO patients, whether it's Secure Horizons or one of the other plans for generally younger patients, the patient's guaranteed a primary doctor.
And a sort of built-in consideration of wellness issues, which for many fee-for-service and even plain Medicare isn't a covered service.
Well, one of the difficulties I encountered as an HMO client was this prior authorization, because it often entailed another visit back to the doctor to get the authorization. And so, number one, why is there a need for prior authorization? And does the process slow things down?
Well, part of managed care is to coordinate the care, and in order to administer a plan at a reasonable cost, you need to rein in unnecessary activities. And by having a prior authorization system, you can coordinate that. In our community, our physicians, by and large, do not churn or utilize inappropriately, and within the network locally, physicians can refer to one another by simply entering the computer and generating a number, and it's done. It doesn't require any extra steps. So it's a very smooth process. And for referrals out of the area, a prior authorization is done, and that again is handled locally and runs smoothly.
From my perspective, it's much smoother than it used to be. There's really no delay to the patient getting from the primary care physician to my office and starting care. And I spoke to my office staff about it. Were there any delays in getting that authorization once we've done our evaluation in our office? And nobody in the office had any difficulty in communicating through the computer or on the phone with the group, and the patients don't experience delays now.
Part of the prior authorization is to determine, is this a covered service? Is this new procedure you're asking for something that's allowed? If you needed a wireless endoscopic capsule to go through your body, is that a covered service or is that investigational? Is this colonoscopy that you're asked for this situation appropriate? Is this new kind of knee procedure you're asking for going to be covered? And so we can find out whether that's a covered service. Has it been proven to be safe and acceptable, and can then validate that through the system.
And is there, well, a couple questions. Let's say you want a second opinion. Is that something that is common or requested or met by the HMO?
By and large, if Dr. Jackson says, gee, I want my patient to see this specialist in San Francisco, and he says this patient has so-and-so problem, it's a slam dunk. It goes right through because it's pretty clear that medically it's quite appropriate. The only time it gets questioned would be where if they say they want to go to Mayo Clinic for that second opinion. That's not in our network. But if they do want a second opinion, they can request that of the health plan. The patient can ask that directly from the health plan.
And is that something that you can negotiate? Let's say the health plan says, no, we don't want to do a second opinion. Is there any recourse? Because I know I've heard of grievances sometimes that come up. Is there a recourse for grievances? Or?
There is a recourse. Certainly there is a system for that. But one of the clear stated obligations of the health plan is if a patient says that they have seen who they want to see, but they want another opinion, they can contact the health plan, and their health plan is obligated to authorize a second opinion.
Okay, that's great. And I know that, Walt, you're a physical therapist, and this is considered ancillary service, ancillary provider. And could you explain what that is and how that fits in, not just with you, but with other ancillary providers, how that fits into the network?
Well, we have a contract with the physician group, and it allows us to be a provider of physical therapy or what are the other services that are ancillary? That
Hearing and durable medical equipment are the things that are needed.
And what it provides for my business actually is access to a large group of patients that are not in, our community is quite a large percentage of Medicare-aged people. And this, allows us to see a wide variety of age groups and also occupations, and gives us a variety of diagnoses to see and post-surgical things to see that we may not see in strictly a Medicare situation. So my staff enjoys the contract because of the variety and the patients that we see. And it allows us, like they've spoken about, to see our friends and neighbors and children of our friends, and it's a nice way to participate.
Yeah, it's one of the benefits of living in a small town, and we've all lived here long enough that, that's obviously one of the reasons we stay here, is because of the companionship and sense of community. The issue that comes up more and more is one of universal health care and managed care. And I wondered if you could describe for our viewers what essentially an HMO is in terms of managed care, and how that will relate to the bigger picture of universal care.
Well, HMO plans are managed care organizations, and Medicare is piloting that sort of plan through its Secure Horizons plans, Medicare Advantage plans, and trying to find out if they can control costs within reason by managing the care. As we were discussing earlier, Gail would speak to the costs.
Well, part of our obligation, I think, as doctors and other people in the medical field, is to make sure that people do get what they need. But obviously, part of that also includes shepherding our resources in a reasonable, appropriate way. We want to make sure that there is money for people to get what they need, and that means that we have to be sure that that money is there, that it's not being spent inappropriately. So I think that if we do get universal health care, it's going to have to be some kind of managed care, because it is the obligation of the medical community to make sure that people do get what they need.
Right.
On our part in the rehab services, what we've noticed over the years, unfortunately I've been in the business way too long, about 32 years, but what we used to get from referrals was 3 to 5 times a week go see the physical therapist. And over a period of time in working with managed care, what we've learned, which was beneficial to the system, is that we can get equally good, high-quality results with less visits if we utilize more education and stressing more home exercise programs. And then the patient comes in and checks with us, and we progress their program. So we get to the same point, but we get there with fewer visits, and they can be utilizing their health club for some of their exercises that they need. And when you look at the end result, they get to the same point at less cost to the system.
Right.
And I think that one of the advantages of having a primary doctor is that we aren't just providing emergency care, as you mentioned before, that we're providing wellness care. It's in everybody's best interest for people to be as healthy as possible. And part of what we do is to try to facilitate that.
It's the idea also that when you go to emergency care, it drives the cost of medicine way up, and with managed care, with a primary care physician, you can actually do preventative medicine. You can do a lot more to shepherding the money where it's best used, most efficiently, and for the best medical purposes. So it makes a lot of sense, and yet, this is a problem we're dealing with nationwide as well as locally. I wonder, have you seen an increase in the HMO numbers?
Well, actually, there's a bit of a decline. There's some erosion in numbers, and it's been declining. Some of the employers can't afford the premium, and so they're going to a high deductible plan which shifts more of the cost to their employee.
All right. John, you want to say something?
Well, I was just going to, again, what Gail was talking about in regards to shepherding the resources. The one thing about having a trusting relationship with your primary care doctor is he or she is a person you trust to say that you don't need something, that additional testing, additional, medication, you're going to better receive those requests from somebody you trust than some anonymous soul.
And as John has said,
We're going to have to wrap it up.
consumers are being bombarded by, ask your doctor for this, ask your doctor for that, you should have this, you should have that. And of course, we want to provide what people need, but we don't want to provide what they don't need.
Okay, I want to thank you all for coming, giving up part of your workday to help people in the community. And I want to thank you for watching NCTV. Again, we'll be back with more information and shows on healthcare in Nevada County. Thanks a lot.
The following program is underwritten by the Nevada Irrigation District. Since 1921, providing clean and healthy drinking and irrigation water to more than 24,000 homes, farms, schools, and businesses in Nevada and Placer counties.